Very good morning to all of you. You are warmly welcome for today's CPD program. The webinar link will be open to you until 10 a.m. and no late attendees will be entertained thereafter. All participants should attend till the end of the webinar to apply for the e-certificate for participation. CPD points will be given to you, which are strictly adhered to the NCCPD guidelines. Anyway, the e-certificate for participation will be given to you regardless of the CPD points. And you can use the chat box for your queries and the answers will be given at the end of the webinar. Also, we kindly ask you to mute your microphones and switch off your cameras to avoid interruptions during the webinar. Now, let me introduce today's speaker, Dr. Wathsala Hathagoda, lecturer at Faculty of Medicine, University of Colombo, and honorary consultant pediatrician at Lady Ridgeway Hospital for Children. Now, over to you, madam.
Good morning. Thank you very much for that introduction. As you all know, I'm going to talk about constipation in children today. So before we move on to the topic, so let me give you an outline for today's speech. So I'm going to tell you the definition of constipation, and we'll be talking about a little bit of the epidemiology, presentation, assessment, and last about the management. So, when we talk about childhood constipation, it is very common. As you can see, the data is varying from 5 to 30% of the child population is having constipation, which is quite a significant number. And out of them, 1/3 will lead to have chronic constipation, which is going to be last for some time. Usually majority are functional, and although we think about organic causes such as Hirschsprungs, but majority are functional, and then early diagnosis as well as the treatment is essential when you think about the chronicity, because once you diagnose them early, it's very easy to treat. Having said that, let's look at our data. This is some of the Asian data we have, where as you can see in Sri Lanka, the prevalence is around 15.4%, which is quite a significant number, which was done in 2012. I'm sure that the number must have gone up further. And when you look at the global epidemiology, the pool prevalence is around 9.5%. So now we all know constipation is a significant problem, morbidity among children. So let's look at what really is constipation. So as you can see in this picture, so there are so many definitions given. Some think it's hard stools, some thinks it is infrequent motions, and some thinks it's just the rectal fecal mass. So because of this discrepancy, group of people gathered together in Rome, as we all know, and then they came forward with this definition. So latest definition we have is Rome 4 criteria, and according to Rome 4 criteria, you should have 2 or more of the following. It could be the defecation frequency, which is less than 2 times per week. Sometimes it could be fecal incontinence. If you have it once per week, even that is considered as constipation. And sometimes there can be retentive posturing or stool retentive behaviors in children. Sometimes they can present as painful or hard bowel motions or large diameter stools, or sometimes in the fecal mass. So if a child is having more than 2 of these, at least once per week for 1 month, then we can diagnose constipation. And again, very important to exclude organic diseases before we label this as functional constipation. So, what causes? Actually, studies, they have looked into the causes which can contribute constipation in children. So in childhood population, what they have found was organic causes like hypothyroidism, metabolic conditions, or the diseases like celiac is very rare. and also the neurological conditions like neuronal dysplasias, neuropathies, myopathies, again extremely uncommon, not like in adult population. Therefore, what we know is more than 95% of children have functional constipation. So it's just there is no organic or anatomical pathology, it's just functional. So which is reassuring, of course. Once we talk about the definition and the epidemiology, let's look at the pathophysiology. I think this is important for us to get the pathophysiology before we move on to management part. So as we all know, when we eat, a food bolus goes from mouth to the anus. The pathway goes from the stomach, small intestine and the large intestine. And the inherent quality of our large intestine is to absorb water. So what happens is, with the peristaltic movements, this food bolus will go towards the anus, and while it goes toward the rectum, more and more water will be absorbed. So as you can see in this picture, once this fecal mass reach this rectum, so then at some point the rectum, because of the stretch receptors it has, then at a certain point it will send impulses to the brain telling that okay, there's a rectal mass, we need to evacuate. That's the place, that's the time we get the urge for the defecation. So what happens then, our brain will kind of control that impulse for some time for us to find a suitable place to evacuate, and then our anal sphincters will relax and we would pass the stool bulk. But what happens in constipation, so due to so many reasons in children, they have a habit of postponing this urge. So what happens, as you can see on the right side of this picture, as a result of this postponement, you can see it has become a large bulk. And nevertheless, because I mentioned you before, the inherent quality of our colon is to absorb water. So what happens when this fecal mass is inside your colon for some time, it absorbs more and more water and it becomes very hard and rigid. So as you can see here, there's a massive bulk of stool which is very hard and stiff in the rectum. And other quality of our rectum is the stretch receptors are not that sensitive when your rectum is persistently stretched. So sometimes, because of this chronicity, because of this postponement, this rectum is so stretched out, and sometimes they will not even get the urge to defecate. So then the problem starts, because then once you try to pass stool, it's really difficult because you have to strain a lot. Once you strain, it can graze the mucosa and then there can be bleeding. And the other problem is there can be bacterial activity around the stool mass, which can cause seepage of water, liquids or semi-solid stools, causing continuous soiling. So which can cause, obviously children will have continuous soiling, and then because of the foul smell, so they are reluctant to go to school, get bullied from their peers, and then parents get anxious, so all the problem starts from there. So I hope you got what is happening with the pathophysiology. So simply that is what is happening. So I already mentioned about soiling, or what this overflow incontinence is. So as we know, it's an involuntary thing. So you can't control that because it's that is a seepage of fluid or semi-solid stools caused by the fecal impaction. Whereas some people can misread this for encopresis, which is again could be voluntary or involuntary. That is the passage of normal bowel movement. That's not only seepage or not only semi-solid, it's a normal bowel movement into inappropriate place. Could be including into the underclothing as well, in a child after the age of 4. Age of 4 means that is the age they get the bowel control. So when they pass a stool in inappropriate places after the age of 4, then we call it as incorporesis, and it could be voluntary or involuntary. So when we get the history, it's very important to demarcate whether it's due to soiling or incorporesis. When we talk about onset, usually it occurs in small age, somewhere around 1 to 5 years, and in some times it can occur soon after birth. So that comes under a red flag sign, because if it occurs soon after birth, then we have to think of other problems, like whether this is something like Hirschsprung's disease, or is it due to a problem due to cerebral palsy, or the other problems. We always need to think about other organic causes. And apart from that, so the other acute problems also can lead to constipation in children. Sometimes the diet, if you are consuming excessive amount of processed food, junk food, which doesn't contain enough, fiber, then again low fiber diet can lead to constipation. Again, same for the fluid intake as well. So what is recommended is to have adequate fluids. So if you are not taking adequate fluid, then then it can lead to constipation. Especially in children, if they are addicted for formula milk, if they are having excessive amount of formula milk, again it can cause constipation. Apart from that, there can be psychological influences, there can be problems. Some children find it difficult to go to the toilets at school, and so as a result they will develop this postponement and retentive behaviors, and there could be problems at school or problem at home with relationships. So there can be psychological elements as well, which can lead to constipation in children. And also it acts as a vicious cycle. Once they get this painful experience, then they will develop the fear to defecate. So it acts as a vicious cycle where they fear of going to the toilet, and then causing chronic constipation. Apart from that, there can be family history, and if you are having a very sedentary life, addicted to phones, screens, and not doing enough physical activities, again it can cause constipation. And also, if you are not giving enough time for, if you are not having a regular toilet habits, again it's a cause which can lead to constipation in children. When we talk about signs and symptoms, because this is very important, when a child with constipation can present in various ways. So only from taking a thorough history and examination, we can decide, okay, whether this is constipation or not. So then sometimes they can simply say, parents can say they are having poor appetite. Because when you are having a fecal loaded colon, obviously they are having a tummy distension and they don't have the appetite because their tummy is bloated. So that may be the reason. Or they can be having lack of energy, and when your bowels, because there's a hypothesis called brain gut hypothesis. So our gut is very sensitive to, our brain is very sensitive to our gut impulses coming from the gut. So when you have any pain or any problem in the gut, you don't feel right. So you could be unhappy, angry, irritable. So same for children as well. And they can have sometimes, occasionally, parents can say they are passing large amount of stools, and there can be passing foul smelling winds all the time, or there can be irregular stool textures, straining or withholding behaviors. So sometimes they just stand stiff, or they just keep their legs in a tiptoe position, crisscross position, so simply they just want to avoid by tightening their thighs. So there can be that sort of positions, and simply they can complain pain in their anus, could be due to fissures or grazes, and they can present with PR bleeding. They might say they bleed from the anus with or without feces, and sometimes they can present with recurrent urinary tract infection. And when your rectum is bulk and your rectum is loaded with feces, it can compress over the bladder and can cause enuresis. So there can be different presentations in children. So here in this diagram I have kind of divided into the age groups in infancy and after infancy, and the how would they present with their with regard to the stool pattern and symptoms. So it's again very important, even in small babies, infants, again they can have symptoms which is suggestive of constipation, so which is very important to elicit from the history. So kind of to make it more easy, so a group of people from Bristol, they came together and formulate this stool chart, which gives a nice explanation about the consistency, because it's very, sometimes it's from the history it's very difficult to get that detail. So if you know how to interpret this stool chart, that is a very simple method of asking the consistency and or type of stool. So type 1, 2, 3, any of this will tell you the child is constipated. 4 would be the normal stool. However, 5, 6, sometimes if they are on balanced diet or if they are on laxatives, you can still explain type 5, 6 as normal, and 7 would be definitely it's liquid, or could be due to diarrhea or excessive laxatives. So to without wasting time, so if you when you get the history, if you can use this Bristol stool chart, that is also very important, where you can get a certain amount of information from the parent. By saying that, not only normal children, but there are some certain special children also will have this problem, especially children with physical disabilities like cerebral palsy. So as you know, they are more prone to get functional constipation because they can be impaired motility in their gut. And apart from that, there can be children who are having Down syndrome or children with autism, again having high risk of functional constipation. The reason I wanted to tell that is sometimes the management would be so challenging because some of the modalities will not able to practice in these kind of children. Not only that, we already talked about this psychological, there could be simply a psychological factor which is leading to constipation. So always addressing that issue also important when we talk about the management. So as you can see, these are some of the studies which have done, including the Sri Lankan children. So it has clearly showed that there can be psychological stressful life events can lead constipation in children. Even in the child abuse and child maltreatment, it's a known fact that it can lead to constipation. Right. So why we need to treat this, and what is the importance of knowing this early and treat this early? Because there can be physiological changes in the body because of this constipation. So one thing I told you, the inherent problem, inherent quality of our colon is to propel the food bolus and then absorb the nutrients and water and then form a stool bulk. However, if you are not evacuating, and then it can lead to a megarectum as well as a megacolon. because your rectum is stretching due to the bulk and it's not being evacuated, so your bowel become very weak and flabby. So that is a problem. And at one point, as I mentioned you before, they will not get the sensation to evacuate. So then your bowel become very weak, and then of course as a result your bowel become overfull with feces, and then they will not get sensation, and it can lead to other problems like loss of appetite, poor oral intake, and poor quality of life as well. So identifying this and addressing this issue is important before they lead it to this sort of a chronic situation. So how are you going to assess? Again, very important to get a careful detailed history and examination, including starting from the birth, because birth history is very important when you think about Hirschsprungs, because always you have to question about the timing of passage of meconium at birth, whether it has happened within 48 hours, which is what is expected from a normal baby, or whether this child has had a delayed passage of meconium, which is important. And then the time of onset of this problem is again important, and the typical diet, fluid intake and physical activity, and the bowel pattern, and if the child is on any medications, because again some of the pharmacological drugs, some of the drugs can cause constipation as a side effect, so you have to get that fact as well. And then the other associated problems like urinary tract infections, and about the behaviors, toileting and the type of toilet and meal pattern, everything is important when you talk about history. Not only that, you need to ask about the stool and the behavior of the child as well as the parents, because if there is anxiety or if there are any problems, again in the management we have to address those issues as well. And whether child being punished due to soiling, or what is the approach of that sort of an incident at school and at home, which is also important to ask in the history. And little bit about the family history, whether it has been going on in the family, because there can be rare neurological or myopathic causes in the gut. Examination again is very important, because we expect you to do a thorough clinical examination to exclude the main to exclude the organic causes. So the growth parameters, looking for growth parameters is very important, because if you see a child with a growth delay, so before you call them as having functional constipation, we have to be very careful whether to see whether we are missing any organic cause. Apart from that, you have to look for the dysmorphism, because there can be dysmorphic, if there are dysmorphism, there can be anatomical defects in the GI tract as well. So because of that, you have to look. Commonest would be the trisomies and other rare genetic causes, where again there can be significant GI involvement. And in abdominal examination, you have to see for distension, scars, and palpable fecal masses, which again will affect the management, because if there are fecal masses, you have to go for disimpaction. So it's important. And not to forget to examine the perianal area to look for fissures, tags or tears. However, the per-rectal examination is little bit controversial in doing in children, because if you are not a confident person, and if you are not confident enough to identify a pathology, then better not to do per-rectal examination in children, because it's not at all a pleasant experience for them. So usually we don't do it routinely unless we suspect an anatomical or the structural problem in the anus, we don't recommend it routinely. And last not least, the lower limb neurology, which is very important because sometimes there can be missed tethering of the cord of the lower spine, and which can simply present as constipation. So always you have to look for lower limb neurology as well. Once you do your history and examination, so the most important thing is to look for the red flags. So if you see any red flags, then you should not think this as a functional constipation. So you have to look for other etiology. So some of these we have already discussed about the birth, passage of meconium, locomotor weaknesses, abdominal distensions or vomiting, which could be due to an obstruction, and if there's faltering growth. And again, on examination, if there are multiple fissures, fistulae, then you have to think of, okay, whether there is an element of inflammatory bowel disease rather than constipation, or if there is evidence of sacral agenesis, scoliosis, then you have to think of other neurological problems. So it's very important to get an idea about these red flags, because you always need to look about these signs when you are taking the history and examination. Once we finish that, and if you have not seen any red flags, so it's a clinical diagnosis, so you don't need any test. So from the history and examination alone, you can diagnose functional constipation. And do we need to do investigations? You might say sometimes we have done these investigations, and you might have seen these investigations being done when you were managing children with constipation. So some of the investigations I have mentioned here: x-rays, thyroid functions, allergy testing, celiac screening. But you don't need to do these investigations in each and every child. But there are some instances where you should do, but routinely it's not indicated. So when we talk about rectal biopsy, which is one of the important investigations we have to do if we suspect Hirschsprung's. Again, that doesn't say that you have to do a rectal biopsy in each and every child. According to the NICE guidelines, these are the indications they have mentioned for a child to go ahead and for a rectal biopsy. In that, there has to be delayed passage of meconium, or has to be constipations in the first few weeks of life, which is a little bit unlikely for functional constipation. And if there's chronic abdominal distension, family history, or growth faltering. Unless if you don't see any of these features, then there's no indication for the rectal biopsy. And next common investigation we order is the X-ray abdomen. Again, if you can remember the definition of constipation, which need 2 or more features once per week for at least for 1 month. By doing an X-ray, which will tell you the status of your colon at that point. That doesn't say this child is constipated, but only thing you can say, okay, whether this colon has feces or not. Again, by doing that, we don't know. There are scoring system where you can measure the rectal diameter and decide whether there is evidence of element of chronic constipation. But without knowing that, without using the scoring system, abdominal X-ray is not a sensitive tool or investigation to diagnose constipation. So which is, again, you are putting your child under unnecessary radiation exposure. Again, you are not going to change your management. So again, it's not going to work unless you suspect a surgical pathology. Then there's a place. Same for the colonic transit studies. You might have heard about this study. It's a radio opaque marker. We ask them to swallow, and then we get serial x-rays usually after 5 days, and we see which part of the gut we can see these markers. So by looking at the markers, we can get an idea about the transit time, the peristalsis and the movements in the gut. So people have found if the time is more than 62 hours, then it's suggestive of significant constipation. And as you can see here, so in this picture on the left, you can see that most of the markers accumulated in the rectum. So this is an ideal patient who is having constipation, where the rectum, everything gathered in the rectum, because of the rectal dilatation, it has not gone out. However, in this picture, as you can see, the markers, they have diffusely spreaded all over the colon. So this is a condition where you will see, you can suspect a problem in the motility. So there's a problem with the colonic motility, so it's a dysmotility syndrome. So in that sort of a scenario, you can do colonic transit study to differentiate the two possibilities, but again, it's not freely available and which is not essential. And if you do this, definitely this child should have refractory constipation, and not for the chronic constipation. We don't do this sophisticated test. Then when we talk about the newer investigations we have, one is this anorectal manometry. Again, you can it will provide information about the sphincter function, anorectal sensations and reflexes. Against limited usage in children because of the cooperation and the practical difficulties in small children, it's difficult to interpret. Same for the high resolution colonic manometry. Again, it check the propulsivity, propagatory contractions in the colon, and then it will tell you, okay, whether the motility is normal or whether they are in dysmotility. Again, not like in adults, we are having very limited studies are limited in children. So once we talk about this, so just to recap, so far what I told, majority are functional constipation, which can be diagnosed from the history and examination alone without needing investigations. So how are we going to manage? That's the most important part. As you can see in this diagram, so this is the management paradigm, which has several steps. As you can see, there are 7 steps, but if you look at the basement, it always says the lifestyle modification. Whereas if you look at the pharmacology, it is in the 3rd stage. So it's a combination of treatment you have to use, starting from the lifestyle, behaviors, pharmacology, biofeedback, and then last, surgical intervention. So we'll talk one by one separately. So what do you mean by lifestyle modification? So any disease, it's very important to educate, because education simply can help you in the management. Because when you're enlightening the parents, so they know the prognosis and what to expect and what is expected from them. Because you have to explain why children can get constipation, and what is the pathophysiology, and what is the management plan, and how are you going to follow them up, and what's going to happen in the long run. So once you give this idea, so the parents, it can relieve the anxiety as well, because sometimes when they're having fecal soiling and when they have problems at school, the whole family can get frustrated, not only the child but also the parents, grandparents, all can get frustrated. So simply if you can counsel and if you can educate this, so it can solve half of the problems, which is a matter of few minutes for you to spend with the parents. Once you do this, then there are a few lifestyle modifications which we need to incorporate. As you can see here, you might have heard, so it says if you eat high fiber, so then it can relieve your constipation. So actually that was a terminology used in the West, because the Western diet is mainly compromised with processed food with less fiber, less vegetables, fruits and leaves. However, still the majority of Sri Lankan diet, still we get enough vegetables and fruits. However, there can be instances, and now there can be emerging problem in most of the urban families where we don't consume enough fruits, vegetables and leaves. So in that instance, the recommendation is they should have a balanced diet. So not too much, it's the normal requirement with all these ingredients you can see in this picture. Not only that, water or fluid intake should be the same. It's not the excessive amount, however the required amount. So we all know there is a requirement for all of us as for the water requirement per day. So these children also should have the required amount of water, not with any other means. They shouldn't be taking frizzy drinks or juice as a requirement, but it's best if they can take them as water. And apart from that, excessive ingestion of fatty food or milk based products or processed food should avoid, because again it can lead to constipation. Apart from diet and fluids, physical activity is also equally important, because if you keep active, your bowels also will move. If you tend to sleep, if you tend to lie down all the time, so your bowel will not move. Therefore, excessive sedentary activity should avoid, like watching television for hours, playing video games for hours. That should be avoided, especially in young children, so because it can lead to constipation. Then what are the behaviors we have to modify? The most important thing, I would say, the toileting or the straining techniques. So there was a debate in good olden days when to train toileting to a child. So the most research and now the evidence is to start from 18 months onwards. So what they say is 18 to 30 months would be the ideal timing for a toilet, to toilet train a child. So it's very important to sit on the toilet at the same times daily, usually 20 to 40 minutes after each meal, because as we all know, our gastrocolic reflex is maximum at that point. So what we recommend for a beginner, to sit after your breakfast, lunch and dinner. So 30 to 40 minutes after your breakfast, 3 meals, you can ask your child to sit on the toilet. And the other important thing is the positioning. As you can see in this picture, so the feet should be on a flat surface. So most of the time if they are on a commode, so you might need to support their feet with a box or a stool, because it's very important to keep them on a flat surface. And also knee should be above the hips, because that flexion is important. And then you have to keep them on this position and then ask them to stay. Initially it could be very difficult for a parent, but what can you do is you can sit with the child. So you can have a potty, for, they are designed for small children, and you can sit with the child and you can have some relaxation, you can have some activities, or you can tell a story about how this poo being formed, or you can sing a song or whatever. So you have to actively engage with the child and encourage the child to stay in this position. Sometimes it could be difficult at the initial time, but once you get this habit, so it's going to be very easy. And then you have to kind of, once they are good enough, then you can gradually explain about the straining techniques, which is not difficult, not possible in small ages. And once they are doing that, you can maintain stool charts, and you can have rewarding systems to kind of encourage the child to comply with this habit. So even in adult groups, that's the main problem which we have seen, because they wake up early morning, they rush to the school, so they simply they don't get a time to go to the toilet. So having a proper toilet time and training is equally important when you are managing constipation. So there are few trials were done with regard to probiotic use. However, so far no evidence, no strong evidence against probiotics, because they have not seen any effectiveness towards constipation. Then the third important thing would be the pharmacological management or the laxative therapy. So here the main principles would be, we have to soften the stool, because as you can remember, I told you in the pathophysiology, in the rectum there can be a bulk of hard, very bulky stool. So you have to soften that stool first. And then the other important thing is, you have to completely evacuate the retained stool, and to maintain that with regular laxatives. And to do that, you have to have a balanced diet as well as adequate fluids and exercises. And clearly you have to get this thing into your mind: dietary interventions alone or the behavioral therapy alone will not work sometimes. So we should not use it alone as first line treatment, because we have to use laxative therapy. Because if you only do a dietary intervention, sometimes it will not effective. Whereas sometimes it might be difficult in infants when they are less than 1 year. So you always need to see if they are pre-weaning, less than 6 months. You always need to see whether they are exclusively breastfed, whether they are formula fed or mixed fed. And then if they are formula fed, you have to always need to look for the concentration, dilution, feed frequency, everything. And for them, we always go for lactulose, which is 2.5 to 5 ml once daily, or sometimes you can use glycerin suppositories. So when they are old enough, as you can see in this flow diagram, you have to confirm the constipation from the history examination, and you have to look for the red flags. If there are no red flags, you have to, you can diagnose this as idiopathic constipation, and then you have to see any evidence of fecal impaction. So it could be the fecal mass, it could be the soiling, or if you have happened to do a rectal examination, so if you might felt a fecal mass, then you have to straight away do the disimpaction first before you go for the maintenance therapy. If there is no fecal mass, then you can straight away start the maintenance therapy. Right, so how would you do disimpaction? Again, best would be oral route, but failing that, you can use the rectal route. So the polyethylene glycol is effective in majority, more than 75%, because it's less painful, less discomfort, and very effective. So that is the most popular and commonest route, commonest drug formulation which we use. And failing that, we can go for the rectal routes, basically enemas. However, putting an enema, it's not a come, you know, it's not a pleasant thing for a child. So usually sometimes they need an sedation, and if you are putting phosphate enema, so you have to always think about electrolyte imbalances. So there can be other preparations like bisacodyl suppositories as well, but the best advice, we have to avoid rectal route as much as possible when we do fecal disimpaction. So how are we going to do that? So this is the disimpaction regime. If you are using polyethylene glycol, so depending on the age category, so this is how you can use. So in this diagram, I think you can see that clearly. So from each age, from day 1 to day 7, so here it has put the number of sachets they can use. So even they can use 12 sachets per day for the disimpaction. If they do not disimpact, if there is a delay or if there is no response, then you can add a stimulant laxative, something like Dalcolax, or you can add a osmotic laxative or things like lactulose. And once you do the disimpaction, then you have to go for the maintenance therapy. And the other important thing, sometimes this could be too risky to try at home. So before you decide disimpaction, you have to consider several causes like the parental understanding and whether there are the feasibility to come to a hospital, because sometimes it can cause massive diarrhea and electrolyte imbalance, which can lead into shock as well. So it's our duty, and as clinicians you always need to think about that possibility as well. And if you think the child is too small, or if the parents are not that sound, so then you might need to get them admitted and then do the disimpaction in the hospital setup. If your polyethylene glycol is not going to work, then the second line would be clean prep. So it's same for the colonoscopy preparation, so same as that. So we give a clean prep, as you can see the different doses I have mentioned here. So again, you can try clean prep, and you can clean the bowel as you are doing it for a colonoscopy. Again, it's very important to monitor the fluid balance as well as electrolytes. Once you do the disimpaction, and it's very important to put them on a maintenance therapy, otherwise they will develop constipation, they will start accumulating feces, and then will have the same vicious cycle again. So again, the first line would be, the best would be again polyethylene glycol. I know few years back lactulose was considered as the best, but however now all the guidelines and evidence in our personal experience is polyethylene glycol has a very good effectiveness in treating functional constipation. So as you can see, even less than 1 year you can use polyethylene glycol, and according to the age you can decide on the daily maintenance therapy. So in this diagram I have mentioned, so what are the doses you can keep. So here I have divided the main types of laxatives. We have the osmotic and stimulant laxatives, and so out of the polyethylene glycol and lactulose we can have magnesium containing medications, as well as docusate sodium, sometimes it is available. And on the other hand, under the stimulant laxatives, other than bisacodyl, you might see senna. But again, I need to stress that we don't use stimulant laxatives alone in children, because it can cause significant pain. So most of the time we combine with an osmotic laxative. So but however, in children with neurological handicap, children like cerebral palsy, we usually start osmotic with a stimulant laxative, but in a normal child we first try with the osmotic laxative, and then failing that only we add a stimulant laxative. So these are the some of the drug doses. I thought it's important when we think about the lactulose and bisacodyl doses in children. And a little bit about the novel treatment. So the world is kind of developing day by day. So there are current evidences coming, but still these medications on trial. So none of them proven to be benefited so far, but there are so many novel medications on trial at the moment. And apart from medications, there are interventions as well. One would be the sacral nerve stimulation. So they have tried to stimulate the sacral nerve and then to improve the transit time. So again, some of the articles, and there are some studies which have shown promising results in patients with refractory or chronic constipation. Okay. So having said that, are there any surgical interventions for childhood constipation? Yes, and those are for children who are having intractable or refractory constipation. So I would say very less than 1%, I would say, will go into that category. And out of the interventions, you can see some of the interventions including the colonic enemas, and there can be resections of the part of the colon or the complete colectomy, or there can be other anastomosis. So this is a colonic enema where you can put a tube from the cecum, and then and there's a tube out, and then daily you can give an enema, so then you can get a bowel wash. Again, very rarely done in children, but other countries they do quite frequently. Right. Having said that, if you see a child who is not responding to your treatment, you always need to think whether the compliance, laxative dose, and the behavioral and lifestyle modifications and the fecal impaction. So you need to address these issues always, and then you might able to find out the problem if you go through this list again. So when to wean these medications, because some of the parents, they are so worried thinking that children can get addicted to these medications, but there are children who use these laxatives for longer time without any problem. However, slow weaning is recommended over 6 months time rather than abrupt withdrawal, because it can cause recurrence of the same problem. So what the recommendation is, you can slowly wean off one medication at a time while you arrange follow-up. So definitely till they get a better toilet training, it's always need to continue laxative therapy. So what do you mean by cure? So if they are having bowel motions more than 3 times per week at least for 1 month, without discomfort, without soiling and without laxatives, then you can call them as cure, and then that is the time you can stop all the follow-ups, and then they can have their normal routines. So what is a prognosis? I would say majority would have a very good prognosis after a period of 6 to 12 months. So they are majority doing well without needing laxatives, but there are poor prognostic features if they present in older age, and if there are problems in seeking medical advice, or if there are other psychological issues. So there can be problems with regard to prognosis, but however it's a very most of the children, they outgrow constipation without having any problem. So last, the few take-home messages I would like to tell you. It is a problem. It is very the number wise, it's 15% of children having functional constipation. So it's a major public health problem, and it can affect the lives of the child as well as the family. And so risk factors are highly prevalent, which are modifiable, including the diet, fluids, and exercises. And routine investigations are not at all indicated, so any doctor should able to treat constipation without needing a specialist. So it's so if you know the concept, so it can be treated easily, and there are novel therapeutic options available for children who are having refractory and refractory constipation to conventional therapies. So that brings to the end of the lecture. So so if you have any questions, so you can ask from this point onwards.
Thank you very much, madam, for your detailed but simple presentation. And actually, we have some present questions and some questions mentioned in the chat box. I will ask, madam, is it okay?
Please.
Some of the present questions have been covered during the lecture, but I will ask again if you have at some points. When do you mentioned about thyroid function test will be a test when which we have to be done at some points. Then when do we need to assess thyroid functions in children when present with the constipation?
Yeah, it's so in my lecture, if you have seen, I have mentioned it's not a routine test we have to do in children. So always it's a clinical assessment. We know in Sri Lanka, neonatal hypothyroid screening is mandatory, and now it's happening in everywhere in the country. So we rarely miss neonatal hypothyroidism. However, there can be acquired hypothyroidism. So in that case, there are some other clinical signs and symptoms you always need to consider. So in that instance, if you think that, okay, there are some concerns, there can be autoimmune conditions which can be running in the family. So in that sort of a scenario, yes, you have to screen, but otherwise I would not say to do routine thyroid screening for any child coming with constipation. I think I have answered your question.
Thank you, madam. If you can again mention what is the normal frequency of bowel opening in infants and children?
Yes. So infants, especially breastfeeding babies, for 6 months and first few months, it's very haphazardly. What we think is, even though they pass 10 times stools per day, or if they pass once in 10 days, still we consider as normal, because having said that, with once we exclude hypothyroidism, so that may be normal. So then again, it's very difficult to kind of tell an exact figure, because they are exclusively on breastfeeding or formula fed. So basically they are on a liquid diet. So because of that, they tend to have increased number of stool frequency. But what we consider abnormal is always we need to know what was the baseline stool frequency. So depending on that, so the parents would know, okay, this child had, or this baby had a frequency of this. And then depending on that, you can decide, okay, whether frequency has come down. For all the children, what we recommend is at least they will achieve the bowel training by at least after 4 years of life. So they can have 3 motions per day in some children, and then some might pass stools 2 to 3 days per week as well. So again, that range is considered as normal, but again, you have gone through the functional constipation ROM criteria. They shouldn't have the other features. And even in a literature, in when we go through, we recently did a meta-analysis to see what is meant by normal bowel frequency, but any of that data, they don't say this is exactly what is defined as normal. So it could be individualized and can be varied from one child to another. But always you need to consider what was the normal baseline bowel frequency.
Okay, madam. Then you mentioned red flags regarding the constipation. Then what are the sinister signs that require urgent treatment? Any other to add?
Yes. So always, especially if children less than 1 year, infants coming with constipation, again, you have to be very cautious before you label them as functional constipation to see, because there are some metabolic conditions, there are some anatomical problems, and some other inflammatory conditions can give rise to constipation. So there are always the first poo. What was the timing of the first poo? Was it happen within first 48 hours? And that is very important when we consider small babies. And also they shouldn't have any evidence of acute obstruction. If there is vomiting, if there is abdominal distension, and if there is kind of failure to thrive. So those are the main sinister things I would say. And anything that you think uh, that doesn't sound like functional constipation, so you always need to think before, because again, in the criteria definition, it always says we have to exclude organic causes first. So you always need to have that thing in back in your mind before you diagnose or call a child having functional constipation.
Is fiber supplementation with commercially available preparations recommended for children?
Actually, it's a very arbitrary idea. Can you give, please? Yeah, sorry for that. So what we say is for fiber, it's again very contradictory idea. So now the latest research, what they recommend is we don't need to give additional fibers. So there's no place at all by taking additional fibers. So the recommendation is to have the what is required. So we don't need to take additional fiber supplementation. It's the normal balanced diet, including the carbohydrates, proteins, minerals. So what we take normally, vegetables, fruits, leaves, that will supply the needed required fiber. So there's no place for commercial fiber preparations at all. That is the recommendation.
Okay, madam. Then any effect of herbal remedies like prunes?
I mean, prunes, we all know it has an effect. And, there are some, local products like we know. So in our Ayurveda medication, there are some, the well-established medications or the things which can cause, diarrhea in people. So prunes, yes, even in the Western countries, they use prunes as a day-to-day supplement to kind of avoid constipation. And there are lots of fruits in Sri Lanka and vegetables and some of the preparations. Yes, so there are things, but the main idea behind, if it is established functional constipation in children, sometimes the dietary modification per se might not effective. So there always we need to go in hand with pharmacological treatment. Otherwise, it can become a chronic problem, causing more problems. But of course, yes, there are dietary supplements which we can use.
Then, madam, you mentioned some regimes can be run up to at least 6 months. Then, how long can use laxatives?
Actually, so in the UK, there are children using on laxatives for years, I mean more than 10 years. So because the constipation is more prevalent because of the diet and the kind of the lifestyle. But Sri Lanka, we hardly see children needing a long courses of laxatives. But again, it doesn't have any addiction and it doesn't cause any side effect to human body. So sometimes, especially in children with comorbidities like cerebral palsy, and there are children who can have neurological impairment, so they are on long-term laxatives. So we, other than, having a little bit of abdominal pain, tummy distension, we don't see much of a problem, but we always need to kind of use them in caution, because if it causes a severe significant diarrhea, electrolyte loss, it can be an issue, but otherwise it's relatively safe.
You mentioned that we have to exclude UTI during our history, madam. Then it has been asked, can UTI cause constipation? Anything to add for that?
Actually, it's the other way around. So what we understand is, because of constipation, it can cause UTI. Because if you can remember my picture of the rectum with a dilated rectum with a large fecal mass. So what happens is that area, your bladder is also in the same pelvis. So it can cause bladder obstruction, causing incomplete voiding of the bladder. So that can kind of, when there's incomplete voiding, so the microorganisms can grow and it can lead to UTI. So it's the other way around. Rather than UTI causing constipation. But sometimes if you are using some certain antibiotics, it can cause transient constipation. But usually constipation leading to UTI.
Anything to add regarding common complications of chronic constipation in children, madam?
Yes, the commonest complication I would say is a psychological problem, because constipation is a disease which can affect the mind and the brain the most. Because if you can remember the brain gut axis, our brain is always sensitive to our tummy. So for personal experience, if you get a tummy ache, you always kind of think about it, because we are so sensitive. Likewise, even in constipation, so when they are having this problem for a long time, so it can affect psychologically, and if you can remember the pathophysiology, it can cause fecal soiling, and then it can kind of cause a vicious cycle, causing bullying, school absenteeism, maternal anxiety. That is one major area. But other than that, the chronic constipation can lead to mega rectum, and then they lose a sense of kind of evacuation, and then they can have some the organic issues as well, but which we don't see much. But basically, the problem we see is the psychological impact in the family as well as in the family.
Then how many days can we wait if baby is constipated?
Yeah, in small babies, I mean, so functional constipation definition, we need to have that for 1 month. So there can be transient instances where they won't pass a poo, like it could be following an acute infection, it could be following some dietary modification, could be due to change in the milk product. So something can cause transient constipation. It depends. I mean, if the child is not in distress, I think, of course, we can wait and watch. But a small baby, breastfeeding baby, if the child is in pain and the tummy is bloated, if mother thinks that child is in pain, then of course we can try a laxative. Possibly the advisable route is oral. Failing that, only we have to go for parenteral, preparations. But of course, you can try an oral laxative and see if it is really distressing the child. But otherwise, you can wait and watch if it is a transient acute constipation.
Then what can be done at OPD and primary care level? You have mentioned the primary management. Anything to add, madam?
Yeah, actually, what I need to say is the most of the time, the failure we do see due to one thing, improper or I would say a low dose prescriptions, and other thing is poor compliance, and other thing is not kind of using for a recommended time, as well as kind of always we need to kind of do it with dietary and lifestyle modifications. I think functional constipation can be treated in the primary care level, and it is not a condition where you need to refer for a pediatrician or to a hospital all the time, except you can start treatment and you can see the response with the maximum treatment. If there is no response, that is the indication to refer. But otherwise, it is a condition which can be treated in the primary care. That's what I want to give. That's the message I want to give.
During the lecture, it covered about the Hirschsprung disease, madam. Anything to add regarding that?
The Hirschsprung is it's a dynamic, I would say not dynamic, but the presentations can be vary. So very rarely there can be atypical Hirschsprungs which can present later. Most of the time the presentation get delayed, sometimes due to the problems in the diagnosis early, because so always if you think, even recently we diagnosed a child with Hirschsprung which was managed as functional constipation for long time. So the basically what I need to say is if you are to try, you have tried your maximum laxatives and then still failing, then I think no harm of referring and getting done a rectal biopsy, because or a contrast study, because always Hirschsprung is a disease where the children can present late as well. So always you need to think that aspect as well. If your child is not responding as you wish, so always it's better to kind of rule out that possibility.
Then, could passing stool in standing position make constipation worsen?
Actually, yes, because if you can remember the pelvic musculature and the anatomy of the colon, rectum, and the anus. So the seating position with the spine straight, leaning forward, that will open up the rectum to kind of pass stools. But if you kind of stay in the standing position, it will kink the rectum and it won't kind of allow the stool pass freely. So that is not at all a good way of passing stool. So you have to make your child train on, to sit on a toilet seat with a straight back, with their feet lying on a flat surface and keeping slightly higher than the buttock. So if the commode is little bit, the height is more, then you can keep a stool to kind of keep their feet. So it's always a seated position. And the squatting. The squatting is the best. In ancient days, most of our, the toilets, we had the squatting pan, and that is the best. But yes, we have commodes now, but the modification would be to kind of sit with keeping the feet on a flat surface, but not at all. We don't recommend the standing position at all.
Give brief dietary advice on breastfeeding mothers for their infant with constipation.
Yeah. So most of the time, even breastfeeding or formula feeding children, sometimes they can get constipation. So I know our parents and the grandparents used to tell, okay, you need to eat this and that, and then I can't say it doesn't have an effect. Yes, there are some food Like, so even you eat prune, even you eat belly, the mango, the fruits and vegetables and the food we consider as causing diarrhea can have an effect in breastfeeding mothers. But if you think um, it's a problem, always we can try a trial of laxatives, that is lactulose, that is what we usually recommend for small babies. So we can try a small dose of lactulose if it is really distressing. But we don't recommend giving water or anything. It's only continuation of breastfeeding.
Some people use soap sticks as a suppository. Is it recommended?
Yeah, actually, I know that we used to when I was a child, I can remember the kind of it was a practice. But what we see is kind of poking into their private parts, not at all a nice experience for children. So that's why we don't recommend doing routine PR examinations. We don't recommend you routine suppositories. So we are trying to avoid as much as possible. If you have observed the younger generation now, they are very smart and they are very sensitive. So even that action can kind of make some unpleasant situation and unpleasant idea about the medications, hospital setup. So I would say we have enough oral preparations. We have enough the things which we can try. So I prefer and I recommend to use oral, and only in trying everything possible, still failing, yes, we had to go for rectal, suppositories and enemas, but not as routine due to the reason I have mentioned.
Then, madam, what are the best laxatives can be given for babies aged below 2 to 3 months?
Yeah, it's a lactulose. So even a Movicol, the polyethylene glycol is recommended, but in Sri Lanka we use it in children above 1 year old. So the best thing we have is lactulose. And if you think, because small babies, they don't remember, they can't recall things. So even you can try a glycerin suppository, but the best would be the lactulose for small babies.
Then, what is the place for prokinetics in management of constipation in children?
Actually, there's no place at all. So prokinetics, we have seen in some instances when we see some delaying in gastric emitting. So if the gastric, it is a drug we use to kind of fasten the gastric empty. Or there can be children who comes with vomiting or abdominal pain, and when we do the manometry, sometimes we do see a delay in gastric emptying. So that sort of a scenario, we use prokinetics, but there's no place at all in constipation. But there are some new trials, they are being tested, but still not in the market. So at the current, when we consider the current practice, it doesn't have any role.
Okay, that's the end of the question session, madam. I thank you again for your very informative and nice presentation. So thank you for today's lecturer, Dr. Wathsala Hathagoda, the lecturer at Faculty of Medicine, University of Colombo, and the honorary consultant pediatrician at Lady Ridgeway Hospital for Children. I thank you for allocating your valuable time on behalf of our medical officers, madam. Then I thank all the participants for today's webinar, and the link to apply the participation certificate has been sent to sent to the chat box. Your comments regarding the webinar also will be very helpful for us on behalf of the future webinars. Then thank you all and have a nice day.
Thank you.